Hi everyone, I'm Ivan Wong. So my topic is peritoneal lymphomatosis in recurrent follicular lymphoma on FDG PET-CT. So I'm come from Queen Elizabeth Hospital in Hong Kong, which is the red dot in this map. Here shows some pictures of Queen Elizabeth Hospital. The environment is quite pleasant, and you are welcome to have a visit after the COVID-19 pandemic. So some little information about the peritoneal lymphomatosis, which is extremely rare, actually momentum, which is peritoneal fold and next the lymphoid tissue, and peritoneal lymphomatosis is associated with aggressive high-grade lymphomas. Some examples shown here. It is also associated with transformation of low-grade lymphomas to high-grade lymphomas. In our case, she was a 63-year-old woman with previous history of rectal cancer, operation done many years ago. In 2013, she was diagnosed with low-grade follicular lymphoma at her left breast, and then she underwent chemotherapy and local regional radiotherapy. Surveillance PET-CT in June 2021 show quite non-specific results. For example, mildly hypermetabolic bilateral upper cervical lymph nodes, FDG-F pleural nodule, assuming mass about 0.5, mildly active peritoneal nodules, which are morphologically similar to previous study, with assuming mass about 2.6. No other new hypermetabolic lymphomatous suspicious lesions detected, and after multidisciplinary meeting, physicians plan to perform CT-guided FNAC for the subpleural nodule. However, her conditions have changed because she presented with abdominal distension, no abdominal pain, there was a bloating sensation, decrease in appetite. She claimed weight loss of about 20 pounds in 1 week. Further questioning revealed no night sweat, no fever, no change of bowel habit, PR bleeding, or tarry stool. She was seen by general practitioner with bedside ultrasound done, which showed intra-abdominal mass. Lab test showed lactate dehydrogenase level on increasing trend. Latest CEA, which is the tumor marker, was within reference range. She was then referred for FDG PET-CT for further assessment. So this was done in our center under the standard departmental protocol. So the patient was instructed to fast for at least 6 hours, adequate oral hydration, avoid strenuous exercise for 24 hours. Her blood glucose was monitored to be less than 11 millimole per liter. So 60 minutes after the IV FDG injection, CT and then FPET images were acquired, and then the images were constructed using the time of flight OSIM algorithm with point-spread function modeling. So for the results, and here shows the maximum intensity projection images. On the left side is the previous PET scan done in June 2021. On the right side is this time PET-CT done in November 2021. The most striking feature is a new extensive hypermetabolic peritoneal nodules and peritoneal thickening throughout the abdomen and pelvis, with SUV mass up to 19.5. There were new FDG-F with para-aortic and right common eyelid lymph nodes. For the background activity in brain, normal liver parenchyma, and mediastinal blood flow, there was a reduction. So here shows some axial images of CT and fused FDG, PET, and CT images. You can more clearly see the hypermetabolic peritoneal nodules and thickening. Here shows the new FDG-F with periumbilical subcutaneous nodule. So here shows new hypermetabolic hepatic lesions. Multiple FDG-F with foci in the liver. And also in another image show increased activity in the liver and also increased activity in the right anterior pleura. There are also mild ascites. The patient has no hepatosplenomegaly. Parancine hypermetabolic cervical lymph nodes and subpleural left lung nodule demonstrate decrease in metabolism, and in the corresponding CT, they were similar or decreased in size. Finally, there is no focal hypermetabolism found at colorectal anastomosis. So the patient underwent biopsy of the periumbilical lesion, and the results show a follicular lymphoma with no evidence of transformation to high-grade lymphoma. The LDH was continued to rise, and the bilateral bone marrow tri-vein exam showed negative results. So the overall findings were compatible with relapse of follicular lymphoma. She was given long-course dexamethasone and then chemotherapy, which consists of obinutuzumab and bendamustine. She had completed 4 cycles of chemotherapy. She tolerated chemotherapy quite well with no more abdominal distension. The LDH was on downtrend, and she was planned to undergo an end of treatment PET-CT in future. So peritoneal lymphomatosis, as mentioned before, is extremely rare. How the lymphoma disseminates through the peritoneal is not quite clear. There are several possible routes of dissemination that have been proposed. For example, through the transverse mesocolon, gastrocolic ligament, visceral peritoneal surfaces. Peritoneal lymphomatosis can cause a severe complication, for example, abdominal compartment syndrome, as well as the multiple organ failure. So peritoneal lymphomatosis can have many differential diagnoses, which can broadly classify into malignancy and infection. For malignancy, the most common one is peritoneal carcinomatosis. The primary cancer can be ovarian, colorectal, gastric, breast cancers. Other possibilities include peritoneal sarcomatosis or peritoneal mesothelioma. For infection, intra-abdominal sepsis should be considered, particularly peritoneal tuberculosis in our locality. So the role of FDG PET-CT is invaluable because it can select the suitable sites for biopsy. By that, I mean sites that are accessible and metabolically active, which increase the possibility of a diagnostic result. FDG PET-CT provide greater sensitivity than multi-detector CT for depicting the peritoneal involvement in subtle cases. It can also identify extranodal sites other than the peritoneal with greater accuracy, even if there is no abnormality seen on CT. So here shows some paper and reporting the comparison of FDG PET-CT to the CT alone for detection of peritoneal seeding. So you can see for sensitivity, FDG PET-CT show higher sensitivity as high as 100%. CT, the sensitivity is about 88%. For the specificity, both are high, around 97%. So how does it look like in the FDG PET-CT? So peritoneal lymphomatosis, the usual pattern is peritoneal superscan. By that I mean intense FDG activity involving the entire peritoneum, and there was decreased FDG activity of the rest of the body, in particular physiological uptake in brain and kidneys. The pattern of FDG uptake in peritoneum can be nodular or linear thickening or bulk mass. Associated CT findings were also important, and you can see omental kicking and diffuse peritoneal thickening. You may also see retroperitoneal lymphadenopathy, bowel wall thickening, hepatosplenomegaly, and ascites. I've done literature review of the peritoneal lymphomatosis reported in FDG PET-CT. You can see for the common symptoms include abdominal distension. Peritoneal lesions are usually diffuse and intense uptake. For lymphadenopathy, you may see, sometimes you may not well see. For ascites, some patients will demonstrate ascites, but usually it is mild. For the underlying lymphoma, the most common one is diffuse large B-cell lymphoma. It can also be a Burkitt lymphoma or a follicular lymphoma with transformation to diffuse large B-cell lymphoma. So, how to differentiate between peritoneal lymphomatosis, peritoneal carcinomatosis, or peritoneal sarcomatosis, which can be based on peritoneal lesions, lymphadenopathy, or ascites. For example, peritoneal lymphomatosis, usually bulky homogeneous peritoneal mass, diffuse and large influx. However, from the literature review shown previously, it can also be few or no influx, as there may be mild ascites. For peritoneal carcinomatosis, there usually be multiple small nodules in the peritoneum, lymphs around the primary cancer, and can be moderate to massive ascites. Peritoneal sarcomatosis, there may be bulky, heterogeneous peritoneal mass, no lymphadenopathy, low or mild ascites. So to illustrate, on the left side, you can see the peritoneal carcinomatosis. There is a small nodular peritoneal masses with mass moderate to massive ascites. On the right, you can see peritoneal sarcomatosis, heterogeneous peritoneal mass, low lymphadenopathy, no ascites. So, having said that, it can be very difficult to differentiate from other peritoneal disease based on imaging alone. In difficult cases, pathological confirmation could be valuable. Tissue diagnosis can also afford unnecessary investigation for a primary carcinoma and delay in initiating potentially curative treatment. So to our knowledge, it is the first report of peritoneal lymphomatosis as the manifestation of biopsy-proven recurrent follicular lymphoma with no transformation to high-grade lymphoma on FDG PET-CT in literature. In summary, extensive hypermetabolic peritoneal lesions are not always due to peritoneal carcinomatosis. The differential diagnosis of hypermetabolic peritoneal lesions have been discussed. Peritoneal lymphomatosis is extremely rare. However, it needs to be considered because the treatment and prognosis can be very different from peritoneal carcinomatosis. Here show the references, and I want to thank my senior colleagues for a facilitation. Thank you very much.